Good afternoon. I am Mark Edison de Vera, and together with Dr. Genevieve Ombao and our co-author, Dr. De Los Reyes, we'll be presenting a research paper entitled Risk Factors for Mortality of COVID-19 Confirmed Cases at Lung Center of the Philippines. So the presenters include myself and Dr. Genevieve Ombao. So novel coronavirus 19 or COVID-19, as we all know, has reached pandemic proportions with over 199 million cases in 218 countries in more than 4.2 million deaths. In the Philippines, there are 1.6 million cases as of August 2021 with over 28,000 deaths due to the disease. And the rapidly increasing number of cases brought a big challenge to public health. Local data tackling disease characteristics and outcomes have yet to be published, and studies on predictors of mortality for COVID-19 cases are lacking. So several foreign studies have already been done to study mortality risk factors, where older age, self-reported dyspnea and tachypnea, as well as elevated inflammatory markers conferred greater risk for mortality. Due to this, we have come up with our general objective, which is to determine risk factors that predict in-hospital death in COVID-19 confirmed cases admitted at Lung Center of the Philippines. Specifically, we aim to determine and compare baseline demographic, epidemiologic, and clinical characteristics to determine and compare baseline clinical signs and symptoms, disease severity, time from illness onset to hospital admission, to determine and compare baseline laboratories, radiologic, and CT scan findings, and to determine and compare initial interventions and procedures of survivors and non-survivors. So this is a retrospective cohort, observational, and analytical study, where study subjects include admitted COVID-19 confirmed cases who were discharged or expired at LCP from March 7 to August 31, 2020. The sample size required was 253 COVID-19 confirmed cases, but we have collected 270 COVID-19 confirmed cases, where 6 patients were excluded due to age and 6 excluded due to advanced directives. Here's a diagram on how we have collected our data. A pooled patient master list from our HESU, as well as the admitted and record section of LCP, was obtained to determine our study subjects. Survivors and non-survivors were also identified. And significant risk factors were extracted through the chart review using a standard data collection tool. Exclusion criteria include those of age less than 18 years old, death at the ER or within 24 hours of admission, those with advanced directives, and those who were discharged against medical advice or transferred to another hospital. So for the resultant discussion, there were 531 COVID inpatients and charts retrieved, but 270 were included in this interim study. 12 patients were excluded due to age less than 19 years old and advanced directives. From the 258 charts analyzed, 174 subjects survived and 84 did not, putting the crude mortality rate at 33%. The mean age of patients admitted was 57 years old and predominantly males. The mean age of non-survivors was significantly higher compared to the survivors. And among the symptoms reported in admission, more survivors reported dyspnea and sore throat as their presenting symptoms. Hypertension and diabetes were the most common comorbid illness of patients with COVID-19, and 2 or more comorbidities were more prevalent in the non-survivors, with chronic kidney disease being more prevalent in the non-survivor group. In terms of disease severity, most of the patients admitted were classified as moderate, followed by critical and severe. Majority who belong to the moderate in severity survived, while those classified as critical did not. On admitting physical examination, the patients in the non-survivor cohort were noted to be more tachycardic, tachypnic, and desaturated at room air, therefore requiring a significantly higher oxygen support on admission compared to survivors. DCS score was lower on the non-survivor cohort compared to the survivor cohort. Baseline ABG showed more decreased mean pH and metabolic acidosis on admission in non-survivors. PF ratio was also lower in non-survivors, And complete blood count on admission revealed increased WBC and neutrophil fraction for non-survivors. EGFR and a lower baseline creatinine uh, was observed in survivors. Among the inflammatory markers, CRP, LDH, procalcitonin, and troponin I were found to be elevated in the non-survivors, and bacteremia was found likely in the non-survivors. AST levels were also higher among the non-survivor group. For the radiology results, consolidation on baseline chest X-ray was found on non-survivors, and most of the patients, admitted patients, received non-invasive forms of ventilation, and majority belong to the survivor cohort. Invasive ventilation on admission was seen more in patients who did not survive, while non-invasive via nasal cannula and at room air was seen in patients who survived. Hemoperfusion and hemodialysis initiated on admission were seen more in non-survivors. So this is just a summary of what was found so far. The following are the significant non-survivor risk factors on the univariate analysis. This table shows the final model showing significant risk factors for mortality determined after logistic regression and multivariate analysis. Autosat, GCS score, and baseline EGFR were found to decrease mortality, and factors that increase mortality were neutrophilic ratio and LDH.
So, good afternoon, everyone. I am Dr. Genevieve Umbao, one of the co-authors of this paper. So, just to review, on multivariate analysis, we found that the oxygen saturation at baseline, as well as GCS score and baseline EGFR, had an odds ratio of less than 1. So, if we put this in a clinical sense, a patient with a low oxygen saturation, low GCS score, and low EGFR at baseline had an increased risk of mortality, while patients who presented with increased neutrophilic ratio and increased LDH at baseline had increased probability of mortality. So the findings of our study are actually consistent with other cohorts done in other countries. So we first go to the low oxygen saturation, GCS score, and estimated GFR. So for low oxygen saturation, this actually correlates with disease severity. In other cohorts done in China by Wang, they actually correlated low oxygen saturation with an impending acute lung injury and cytokine storm, while other cohorts, again done in China, also found that low oxygen saturation was the most powerful predictor of in-hospital death. So for low GCS score, this also connotes end organ damage from sepsis, consistent with the findings of other studies in Italy, where a low GCS score and a previous history of stroke were actually risk factors which conferred increased risk for mortality. And as we all know, a low GCS score is actually a component of other scoring systems such as the SOFA scoring, which we all know is also predictive for mortality. So a low EGFR connotes intrinsic acute kidney injury from COVID-19. This involves direct attack of the virus to the proximal tubular epithelial cells, which are rich in ACE2 receptors. For increased neutrophilic ratio, we found that this is a direct correlation to the pro-inflammatory response. So this leads to the preferential production of neutrophils and the subsequent apoptosis of lymphocytes, while the increased LDH heralds a cytokine-mediated tissue damage and or injury. So this correlates with acute lung injury from severe interstitial pneumonia, often culminating in ARDS. So to conclude, oxygen desaturation, low GCS score, and a decreased EGFR at baseline, as well as increased LDH and neutrophilia, confer increased mortality for COVID-19 patients admitted at Lung Center of the Philippines. Knowing which parameters confer the increased risk for mortality can guide the healthcare team in appropriate management for COVID-19 patients. So our study had its limitations because of the incomplete retrieval of medical records from more than 500 COVID-19 confirmed cases. So as Edison discussed earlier, we only retrieved 270 charts for analysis. Um, and the clinical parameters were mostly self-reported by our patients, and some laboratory tests were done at different institutions due to unavailability. Others also were not included in data analysis, such as BMI, due to incomplete reporting. So ultimately, the goal of this research is an eventual creation and validation of a mortality scoring system, like the one that they did in the United Kingdom. Uh, this is to ensure that the allocation of limited resources will go to the appropriate patients, and if we can predict those patients with increased probability for mortality, then they will receive, or they will warrant closer monitoring and more aggressive management. So thank you and good afternoon.
One of the most affected groups of COVID-19 pandemic is dialysis patients. Today, I will present our study entitled Risk Factors for In-Hospital Mortality in Peritoneal Dialysis Patients Admitted with SARS-CoV-2 at the National Kidney and Transplant Institute, a retrospective cohort study. I am Dr. Melhatra Arakama from the National Kidney and Transplant Institute, and my co-authors are Dr. Ramiro Danilan, Dr. Renamar Garcia, and Dr. Francesca G. De Leon. So the worldwide mortality of acute of COVID-19 is 2.18%. Among the general population of the dialysis patients, there are 31% mortality rate, and among intubated patients, there are 75% mortality rate. If we break further the dialysis patients, the hemodialysis mortality rate is 33.76%, and the peritoneal dialysis mortality rate is 45.6%. Therefore, we can clearly see that ESRD patients are at increased risk of COVID-19 and its complications, which can be attributed to high exposure risk, elderly population, having multiple comorbidities, and suppressed immune system. Currently, there are more than 369,000 ESRD patients on PD, accounting for 11% of the global dialysis population. As of September 2020, NKTI has 1,119 active chronic PD patients, the biggest PD patient population in the country. The 2020 NKTI COVID-19 census for patients on dialysis from February to December 2020 had noted of 670 patients. 22% were on peritoneal dialysis, 77% were on hemodialysis. The mortality rate for PD was 12%, and the mortality rate for HD was 33%. The objective of this study is to determine the risk factor for in-hospital mortality of chronic PD patients diagnosed with COVID-19. The specific objectives are to determine the profile, baseline clinical presentation, laboratory parameters, treatment and management strategies, and outcomes of the patients. To determine the relationship between PD prescription and in-hospital mortality among PD patients infected with COVID-19, and to determine the relationship between baseline clinical characteristics and laboratory parameters with in-hospital mortality of PD patients infected with COVID-19. This is a retrospective cohort study which included all chronic adult PD patients admitted at NKTI with COVID-19 from March 2020 to September 2020. The statistical analysis are as follows, as listed. It included patients on PD from 18 years old and above for at least 1 month and positive for COVID-19 by RT-PCR. Patients excluded were PD patients who expired prior to obtaining COVID-19 PCR results and patients with a dysfunctional PD catheter on admission, such as PD migration and omental wrap. There were 74 chronic PD patients diagnosed with COVID-19 included in the study, with an incidence of 6.6%, which is lower compared to HD patients' incidence of 18%. Our results showed a younger age group, male predominance, and difficulty of breathing as the most common presenting symptom, in contrast to a multi-center study by Zhang with a mean age of 55 years old, with female preponderance and difficulty of breathing as the most common presenting symptom. Similar to our findings, is negative kidney disease as the native kidney disease is glomerulonephritis. The mean PD vintage was 20.86 months. Most PD patients had severe COVID-19 infection at 41.89%. Severe COVID-19 disease has been attributed to direct viral damage and to the body's exuberant immune response. The diminished immune response in renal patients could protect against the cytokine storm. However, it can also mean that they are less capable of mounting an immune response against the COVID-19. Notably, those who died had lower BP on admission, though not significant statistically. Abdominal pain, difficulty of breathing, and cough were the three most common presenting symptoms on admission. A case report described an atypical presentation of COVID-19 in a PD patient showed GI symptoms and very minimal respiratory symptoms. The patient had nausea, vomiting, abdominal pain, and tenderness. According to another study by Nang, independent risk factors for in-hospital death included increased age, lymphopenia, elevated BUN, high lag-transformed serum ferritin level, need for mechanical ventilation, and vasoactive medications were factors that are associated with mortality. These factors were not seen in our study. Instead, logistic regression analysis found that anemia, leukocytosis, severity of COVID-19 infection, abdominal pain, and desaturation were the independent risk factors for in-hospital mortality. Among those with abdominal pain in our study, 46% had culture-negative PD peritonitis. In a local study done in NKTI in 2001 on CAPD peritonitis, from 1996 to 1998, gram-negative bacteria was the most common causative agent for PD peritonitis in NKTI, with culture-negative peritonitis occurring in only 27% cases. A similar study by Libarius et al. in NKTI showed that most PD peritonitis were still due to gram-negative organism. Hence, one can speculate on the possibility of viral translocation during severe COVID-19 infection on a possibility of COVID-19 related peritonitis, since abdominal pain was noted to be a predictor for mortality. It is also possible that a coexisting PD peritonitis leads to UF failure and more complications, hence a higher mortality rate. This is just showing the different organisms showed in the PD culture of the patients in international and in KTI. Per day, a lower number of extras per day and a greater volume of ultrafiltration per day were significantly associated with survival. Among those on CCPD, only a greater ultrafiltration per day was significantly associated with survival. This would imply that the volume of UF per day was more important for survival compared to the number of exchanges per day. ISPD recommends that with mild to moderate COVID-19, PD prescription can continue. For those with severe or critical infection requiring life support, they can be temporarily transferred to automated peritoneal dialysis or continuous renal replacement therapy. This table shows that the outcome of PD patients admitted with COVID-19, the average hospital stay of patients was 17.5 days. Inpatient hospital mortality was 20.27%, and 32.43% of them were shifted to hemodialysis. At 30 days from admission, 2 additional patients who were discharged died, bringing the 30-day mortality to 23%. This is low compared to hemodialysis mortality rate in NKTI of 33%. Among the baseline parameters tested, logistic regression found that severity of COVID-19, abdominal pain, decrease in O2 saturation, elevated WBC, low hemoglobin, and WBC significantly predicted mortality. The conclusion of the study included COVID-19 infection occurred in 6.6% of PD patients with an in-hospital mortality rate was 20.27%, which is lower compared to the global data as mentioned earlier, and associated with non-survivors. Higher daily ultrafiltration in both CAPD and CCPD were significantly associated with survival. Strategies to increase ultrafiltration, including a temporary early shift to CCPD and hemodialysis, may be warranted. Independent risk factors for in-hospital mortality rate include severity of COVID-19 infection, hypoxemia on admission, presence of abdominal pain, anemia, and leukocytosis. The presence of these factors on admission may signal a more morbid course and warrants close monitoring and aggressive management. Abdominal pain was noted among severe COVID-19 patients, which can be attributed to a possible COVID-related PD peritonitis. A recommendation from this study is a study that will determine PD effluent RT-PCR can be done among severe COVID-19 PD patients to further elucidate on this matter. From this study, policy implications were recommended. PD is an ideal form of renal replacement therapy, especially in an infectious pandemic such as COVID-19, to lessen the risk of infection, the transmissibility, the mortality, and the morbidity rate, because patient performs their treatment at home, so there is less risk of exposure to other patients and healthcare workers. There is no need to that will accommodate patients if they get mild to moderate COVID, since they do home-based therapy. We also recommend to strengthen the implementation of the PD First policy of DOH and the PhilHealth, to capacitate the hospitals to do PD and adapt the PD First policy to increase the accessibility of PD in our archipelago, and to increase the PHIC coverage for PD now that PHIC covers more HD sessions. This is to encourage patients to do PD. Thank you, and if you have questions, thank you.
Okay, so good afternoon, everyone. I will be presenting my research entitled Association Between the Disease Severity and Quality of Life of Psoriasis vulgaris Patients in a Tertiary Government Hospital in Pasig, Metro Manila, Philippines, a retrospective cross-sectional study. I am RB Sofia P. Meriliano, a dermatology resident from Rizal Medical Center. And on behalf of my co-authors, Dr. Francisco Rivera IV and Dr. Maria Charlene Temblique, I will be presenting our research. Psoriasis has garnered global recognition worldwide due to its high prevalence. In the Philippines alone, about 1.8 million Filipinos are suffering silently with psoriasis, a chronic, non-communicable, painful, disfiguring, and disabling disease according to World Health Organization. This disease results to physical symptoms, as well as economic, psychological, and social impact to patients. There is a misconception that psoriasis is only a skin problem. In fact, it is associated with several comorbidities such as metabolic, neurological, mental, and autoimmune diseases. Locally, the number of studies on psoriasis is increasing. However, there is still very limited information, especially on the epidemiology and clinical characteristics pertaining to psoriasis. Information on the severity of the disease, demographics, and clinical characteristics of patients has a bearing on the behavior, prognosis, and treatment of the disease. Therefore, knowing these factors, we can contribute to a better understanding of the burden of psoriasis, updating population research, and advancement of health policies in our country. This is especially important in today's pandemic situation, where overall well-being of patients, including those with psoriasis, are deeply impacted. As a measure to curb the spread of the virus, Philippines passed temporary laws to close or reduce hours of non-essential businesses, schools, and the like. Lockdowns are put in place, limiting gatherings and outdoor activities. These led to less social interactions and loss of source of income, resulting to pandemic-related stresses, increased depression cases, and flare-ups of psoriasis patients. Moreover, before the pandemic, psoriasis patients already have limited access to treatments and therapies to manage the disease, which is worsened due to high economic burden and limited access to healthcare systems brought by COVID-19. In Rizal Medical Center, Department of Dermatology, we have recorded an increase in the number of consultations of psoriasis. It remained as the highest top disease managed by the department. Therefore, we should give focus as well to non-communicable diseases, including psoriasis, even during the pandemic. With that, this study aims to determine the association between disease severity and quality of life of patients with psoriasis in Rizal Medical Center and Referral and Training Center for Dermatology, as well as the association of demographic profile and clinical characteristics of patients to disease severity and to their quality of life. To achieve this, an analytical cross-sectional study was conducted through a retrospective review of charts of psoriasis patients on their initial consult at the Dermatology Outpatient Clinic of Rizal Medical Center between January 1 to December 31, 2019. Medical records such as the psoriasis registry forms that contains the demographic and clinical characteristics of patients, baseline PASI and DLQI of psoriasis vulgaris patients aged 19 years and above were retrieved and included in the study. In case of missing values from the psoriasis registry form, patients' records in the electronic health records, which is a web-based registry of Rizal Medical Center, were used to check and complete the data. Patients lacking information were excluded in the study. The data were then encoded and analyzed. The severity of psoriasis were measured using the Psoriasis Area and Severity Index, or the PASI. It is physician-reported and combines the assessment of the severity of lesions and the area affected into a single score in the range of 0 to 72. A score of 10 or less signifies a mild form of psoriasis, while a PASI score of more than 10 means that the psoriasis is moderate to severe. The quality of life was measured using the validated Filipino version of the Dermatology Life Quality Index Standard, which is a 10-point questionnaire to measure the impact of skin disease on the quality of life of an affected person. So a DLQI score of 0 to 1 has no effect on the patient's life, 2 to 5 has small effect, 6 to 10 has moderate effect, 11 to 20 has very large effect, and 21 to 30 has an extremely large effect. Multiple linear regression was done to identify the predictor variables of DLQI and PASI performed at 5% level of significance. The results of this study showed that out of the total 155 participants, 43% are mild cases, while 57% are moderate to severe cases. Meanwhile, majority of the patients believe that psoriasis has a very large to extremely large effect on their quality of life. Some believed small to moderate effect, and only a few concluded no effect. The mean PASI score was 14.72 and the mean DLQI was 13.95. And as shown in this table, we can conclude that disease severity and the quality of life were highly correlated, where severity of psoriasis is directly proportional to the impairment of quality of life of patients. Psoriasis results to huge impact to patients physically, psychologically, socially, and economically. This is aggravated when patients suffer from moderate to severe cases of psoriasis. Therefore, similar to other studies, our results show that when patients suffer severely with psoriasis, they experience worsening of their quality of life. Furthermore, checking the association of demographic and clinical profile of patients to disease severity, we found no significant relationship. However, it can be highlighted that there is a strong association between psoriatic arthritis or joint involvement and disease severity. This can be supported by several studies that suggest that patients with high skin severity are 2 times more likely to have increased joint involvement. Meanwhile, on quality of life, several demographic and clinical characteristics show association. Ages 19 to 30 and ages 51 to 60 show significant correlation to lower quality of life, and no significant association was seen on other age groups. Psoriasis causes visible disfigurement, resulting to lower self-esteem and body image dissatisfaction, which is highlighted by social media's beauty standards, especially for the younger age groups. Meanwhile, for the elderlies, they usually fear that the disease is transmissible, so they stay away from their families and limit their social interactions, causing mental health issues and worsening the quality of life. Meanwhile, as dermatologists would always say, psoriasis is more than skin deep, as the presence of cardiovascular comorbidities is highly associated with impaired quality of life as shown in this study. So these diseases aggravate the burden of the patient as it negatively impacts daily activities of the patient. Financial burden of psoriasis to patients is substantial, and to suffer with other comorbidities brings additional threat to the financial and social status of the patients. We can also observe that depression is associated with an impaired quality of life. More than 10% of psoriasis patients suffer from clinical depression, and twice as many have depressive symptoms. Flare-ups and relapse of psoriasis cause the increase in the occurrence of depression, especially among the moderate to severe psoriasis patients. The coexistence of these conditions is expected to have a burden on the quality of life, especially since depression is treated only upon identification and evaluations of proper clinicians. As dermatologists often have limited knowledge in psychiatry, psychological burden on psoriasis patients is left untreated. Quality of life of patients was also affected by the presence of family history of psoriasis. This is likely due to the patient's self-perception on the distress and burden experienced by close relatives. In several studies, psoriasis affects not only the quality of life of patients themselves, but it also involves the quality of life of their family members. To experience this negative impact on their well-being, it increases patients' fear and psychological distress. Moreover, similar to the disease severity, quality of life was highly correlated among patients with joint involvement. This is due to the impact on limitation on the physical activities of patients. It is necessary to emphasize that this study has limitations. This study design is a cross-sectional study. Therefore, while associations may be identified, the results will not imply causality. Furthermore, this is not a representation of the general population, as data is limited to 1 year and is only based on a specific hospital, the Rizal Medical Center, and Referral and Training Center for Dermatology. The design also lacks a control group which analyzes the quality of life of non-psoriasis patients. Hence, the comparison between the healthy and non-healthy individuals is not possible. In conclusion, psoriasis affects the physical, psychological, social, and economic well-being of a patient. There is a significant association between disease severity and quality of life among patients with psoriasis. Age, cardiovascular comorbidities, depression, family history, and joint involvement were associated with impaired quality of life among patients with psoriasis. We recommend that for future studies, a longer duration of data. Also, it is recommended that clinicians to always take a holistic approach when managing patients with psoriasis and address their needs to improve their quality of life. Again, psoriasis is more than skin deep. So an integrated management of the disease and other comorbidities, including medical and psychiatric, should be evaluated and administered to patients. They should be referred to other specialties which can manage their comorbid conditions, which further aggravate their quality of life. More so, we should also support the initiatives and measures to strengthen the country's health programs in battling psoriasis vulgaris despite the pandemic. Health services have been partially or completely disrupted due to the COVID-19 pandemic. In the Philippines, we have limited access to healthcare systems, especially for non-emergency patients like psoriasis. And although this disease is non-life-threatening, this study has shown the importance of managing the disease. COVID-19 has affected and will continue to affect the well-being of patients and for some time the management of patients with psoriasis. Therefore, it is imperative to support different government and private initiatives, such as the House Resolution 719, to raise awareness on the diagnosis, management, and treatment of psoriasis. Researches also suggest that telemedicine, increased supply of medications, and the health interventions are needed for patients with psoriasis in order to improve their health outcomes, especially during this time of the pandemic. With that, I would like to thank you all for listening. Ngayong panahon ng pandemya, naway maging daan ang aming ospital at ang DOH sa pagbigay ng atensyon sa tamang paggamot ng psoriasis, lalo na ngayong panahon ng pandemya.